So just so you know, our session is going to be recorded so that others can benefit from the information here if they have not attended tonight. So right now we're simply waiting on people to kind of give us a little profile of what their feeding problems are so I can better address them throughout the presentation. Okay, so Carrie, you shared with us that your son is 10 years old and he often isn't able to sit still long enough to eat or force any or focus on the food. He also doesn't like the textures of some food, too crunchy, too hard, etc. Okay, thank you, Carrie. Jenny, were you, or Jenny or Beverly, if either of you could type just the same kind of short scenario to let us know, you know, how we can interact with your child. Oh, Jenny, you're not able to type. Are you on a phone? It looks like it. And then Beverly's typing right now, so. So Jenny, you said Penelope is 3. She is mostly a good eater but doesn't want to try new foods. Sometimes if she doesn't want to eat something that she doesn't like how it looks. So she doesn't like how certain foods look. And we're going to start right off with talking about why that is and how that is typical it kind of goes with the diagnosis of autism. And again, we'll get these protocol or these little vignettes going, and then after that, I'll ask you guys to hold back on some of your questions. If you could just raise your hand when you have typed a question, because sometimes I don't see it in the lower box when I'm going. And so let's do that. Carrie, he often comes home with a full lunchbox saying he wasn't hungry, and my son always wants to eat my son also won't eat anything if he doesn't like the look of it too. Okay, so again, it sounds like you share some of those similarities with Jenny and Penelope, where if it doesn't look right to her, if it's not the same color, or if it's not the same texture that she's seen before. And we'll talk about that sameness and how that really ties in with autism. Okay, so we may have lost somebody. Hopefully they come back on. I'm going to go ahead and get started. Again, if we have someone joining us, I'll ask them to give us a short vignette and kind of back up just a little bit, hopefully not to delay our time together. So what is a feeding disorder? And I want you to focus on the word disorder here, because that's what I'm describing, because that's where our children have the inability or refuse to eat or drink sufficient quantities of food to maintain their nutritional status. So they're refusing. They're your low weight babies. They're not on the curve that we want them to be, and nutritionally they're not taking in a variety of food that would support them. So initially I talk about disorders, but we're going to talk about the other side of it, where it may be more of a picky eater, which both of you have described. So the DSM-4, and I don't have the DSM-5's new version, but they really haven't changed the feeding disorder diagnosis. Basically, to have a disorder diagnosis from a hospital and your insurance just accept it as a feeding disorder, the feeding disturbance not associated with a gastrointestinal or another medical condition, so resulting in insignificant failure to gain weight or a weight loss for at least a month with the onset prior to age 6. So this is what they look for when they're doing the medical diagnosis, and this is what insurance is looking for billing. So we're talking about this is just talking about the disorder itself if you were to go into a hospital. And I do have a list of different areas, different aerial hospitals that do take care of feeding interventions. So guidelines to determine if your child has a feeding problem. They may not be gaining weight and have what's called failure to thrive. We used to have a little cute little nickname for them. I don't know if you guys remember the Planters Peanuts little guys, but that's what we would refer. Oh, there's the little peanut coming down the hall. They were just so cute, and they shouldn't be walking because they didn't have the weight on them that you would expect them to have at that age. They also may be tube-fed dependent and have no oral skills, so they've never really used their mouth to feed, so they may not have those oral skills. They may have problem with age-appropriate textures, which is related to the oral motor skills. They may have refusal of age-appropriate varieties, and that's kind of what I'm hearing. Even though we have 3 and 10 years old, we may have some age-appropriate variety issues going on as well. The fact that you guys both talk about texture issues, and I wonder if it's a matter of whether they have the skills to handle those higher textures too. Sometimes kids don't, and we need to take a look at that. Mealtime behavior disruptive to family and function. I think you both have joined us because of that reason. And then chewing or swallowing problems. And again, the oral motor part of breaking down food is very important. Very important. So who and why? Feeding disorders affect nearly 25% of infants and children, and up to like 30% of children with disabilities have some form of feeding difficulty. The interesting thing about it, the unusual pattern of food acceptance used to be a marker for autism, yet the reports were mostly anecdotal, and they kind of stepped away from that as a diagnostic criteria for autism, yet it's very, very frequent in our children on the spectrum because of that characteristic of them liking sameness. They like to have the same fork, or they like to have things in the same order, or they get very upset. If it doesn't look the same, they're not going to eat it. And that's a big characteristic of autism when you look at that, they like to have the toys lined up in a certain way sometimes, or they like to talk about a specific topic. That's that sameness that we have difficulty with when we're trying to get them to increase the variety of food. So it's not uncommon to have that in children on the spectrum. And I see Beverly's typing, so as soon as she's finished, I'll make sure I answer that. There's another, so we're talking about children with disabilities, that's a reason why that they may have some food disabilities. And then medical or motor or oral motor or sensory issues, they usually play a huge part of the development of feeding problems. So I always say, and we're going to spend quite a bit of time in the beginning talking about the medical part of it, it is so important to have your child medically cleared before we do any kind of behavioral intervention. We can have the best behavioral protocol and just continue to maintain poor feeding behaviors because something medically is going on. And we're actually increasing or hurting the child more. So we always ask that we work in a team, and you're going to hear this throughout the whole presentation. You really need to have a team of experts working with children who have feeding issues. That includes your your PTs, your occupational therapists, your speech pathologists, and your gastroenterologists or your GI doctors. The final thing that we're going to be talking about later on tonight is environmental factors also commonly play a role in maintaining these behaviors when the other issues are resolved. So what we are doing as parents may be maintaining a lot of the behaviors that are going on at the feeding table. So we're going to talk about those kinds of perspectives as well after I discuss the medical issues. So Beverly types, my 7-year-old has pretty much the same problems as Carrie's son. So you guys are sharing some of the same things. You're talking about possibly textures, not wanting to sit too long, sitting at the table, and if the texture doesn't look right or if the food doesn't look right, they may not eat it. So that's good, and I'll be able to refer back to those. Beverly keeps popping up. I feel bad for her. Okay. So what are the autism-specific findings? And this, again, is kind of back to what I said. The behavioral characteristics, as you guys know of ASD, is instinctive sameness and the restriction to change. They like predictability. Well, we could do that if we put pizza in front of them every night, and that would be predictable and it wouldn't change, and they'd probably be happy if pizza is their preferred. But that causes a huge issue in the variety of foods that our kids will eat, that sameness, and that's why we see it so frequently in children on the spectrum, is because of the basic behavioral characteristic of sameness when children are diagnosed with autism spectrum disorder. Sameness in the daily routines that they like, sameness in their play. This comes directly from the book that I showed before, and it is down in the notes on the side. That's the title of the book, and Keith Williams and Richard Fox are the authors of this book. What's interesting, in 2004, there was a systematic survey of parents, both, for two different surveys, where parents both found that 90% of the parents with children with autism had some kind of mealtime problem. So again, it kind of supports this sameness idea and the fact that it's not unusual for kids on the spectrum to have behavioral feeding problems. Many of the doctors would say, oh, simply ignore it, they will grow out of it. Some may, absolutely. Yet if we continue to reduce our variety of food to present to them, then they don't have exposure to it. There's a slide in here in my presentation that's going to tell you how many times any individual, has to taste a food prior to them gaining some kind of affection for it, or we like it, we like the flavor, we like the color, and I think you'll be pretty surprised. But ignoring it doesn't always work with our kids, as we can get them stuck in a rut with that sameness, and so we have that special green cup, and that's the only cup they drink out of, and then when the dishwasher finally ruins that cup because it's been washed so many times, then we have a problem. That also happens with one of the boys that came into the feeding units when I was working. He was only eating macaroni and cheese, and that was it, and it was Kraft macaroni and cheese, and at the time it had a tiger on the box. Well, the company decided to change their advertising and change the color of the box. Mom saved and saved her last box, kept putting macaroni and cheese, even though it was Kraft, in that box so that he would eat it, and finally it got so tethered he started to recognize that, and he stopped eating altogether. So that environmental factor that you saw on the slide before, she actually created it for him not to eat anymore because she was showing him the boxes, showing him the cartons. This is like the #1 thing you can stop doing right now, and it'll increase the child's variety. Stop showing the containers and the boxes that the food come from. I know that they're tricky. I know that they can see the differences in chicken nuggets, but if we stop showing the boxes, we're going to increase the variety. Plus, it might save you a few pennies when you're shopping for different chicken nuggets if you need to save. So that leads right into that limited exposure to tasting foods. This is the slide I was telling you about. A preference for a food. You have to try and taste a food 10 to 20 times before you acquire a taste for a food. How many of you thought, just by raising your hand, go up to this little guy and tell me, how many of you knew that it took 10 to 20 times to taste a food before you acquired it? If you guys can go up to this little guy and agree or disagree and let me know. I find it pretty surprising. See, Carrie, what we do is we take the food right away. Oh, he must not like it, or he doesn't like things that are green. So then how do we know? So, 10 to 20 times before a person knows if they like a food or not. And that's anyone. So we limit the diets. Many of our kids, and it's Bill Ahern, who was my director at the feeding program, has written several journals and books on feeding, and limiting the diet to starch and milks and gluten, casein free. There's little research on how diets affect eating problems. What he's really concerned with, and so we have a kid already that's limiting their variety of food, period. And then we say, okay, we're going to go gluten, casein free, and now we're restricting the child's diet even more. So they're not eating what we had. Now we're trying this gluten casein free and it doesn't taste as well as the others did. Now we've increased the number of foods that the child won't eat. And so we're making them kind of slip into more and more restrictive diet. So he talks about focusing on providing methods to ensure nutritional balancing the diet, if that's what we need, instead of looking at like a gluten casein free diet, especially with kids who are already restricting their intake. And to me, it sounds pretty viable that that's what we would do. So what's the difference now between a fussy eater and a feeding disorder? Some of the key factors is the impact of the refusal behavior has on the child's psychological and mental health. Okay, so our fussy eaters may eat a restricted variety of foods, but kind of across food groups. If I had you in front of me, this is where I would ask you, what kinds of foods are your kids eating? But if you could quickly kind of jot down, I mean, do starches, proteins, vegetables, are they eating some in each category, or is there some categories that are completely missing? A child with a feeding disorder may consume only 3 or 4 foods or eliminate entire groups. That, of course, will compromise their physical and mental development. So when you're thinking about what they do eat, what I'd like parents to do, and it's in this book too, there is a food diary, and I really encourage you to take a food diary. What are they putting in their mouths? What are they eating throughout the week? It might surprise you that it's more than it was. It also lets us know what they're not touching at all. You know, Carrie, great, you know, vegetables, he'll eat some vegetables, limited proteins, pasta, and rice. Okay, so, you know, again, that starchy diet that they like, and that's that sameness. Remember that idea for sameness, so they all kind of really look the same. But it looks like there's a variety, but you want more in there. I don't see a lot of crunchy foods for Carrie unless the vegetables are raw. And again, you've got to try 10 to 20 times before the child likes it. Jenny, you've got chicken nuggets, quiche. Oh, I love quiche too. And chips. But, you know, I wonder how much of that is, I wonder how much of that is our restriction too. We've decided that these are the things he likes, so I'm not going to try some other things. And that's why you guys are here, because you're wondering what else to do. Jenny says limited vegetables with the stuff, and quiches are great because I'm sure you can put a lot more in there to get a few different nutritional things in there, like your vegetables. Not even coated chicken or fish, Carrie, yeah. And some kids don't like the breading, and some kids do. So it's great that you guys take an inventory. That's the basic thing I want you guys to know is, and in the book in the back, there's a food inventory that you can copy. You can copy a lot of the things out of the book. They've given permission, and it makes you take a look at it. What's nice is you can sit with your coordinator, or they can sit with me at the office. We meet every 2 weeks, and they can go over the foods, and they can say, okay, what do you think, Kim? What does this look like? Or how can we get started? Or they attended your training. So we'll have, you know, taking a look at what you have in your variety now will also help me identify the foods to start with, and we'll talk about that later. So how feeding skills develop. And so we're going to talk a little bit about the anatomy and get more into some of the medical stuff right now to kind of help you guys understand a little bit more about how it gets started. So our oral cavity, specifically our teeth and our jaws and our tongue, work closely with the structures used for breathing. So if we have a kid that has a problem, that they may be what's called low tone, and they're floppy is another word that people use to describe them, they're going to have probably difficulty eating and breathing at the same time. So it's going to have a lot to do with positioning to make sure that they're sitting in a nice 90-degree angle. Kids that are wheelchair bound, we often have to reposition them so that their airways are completely free. Beverly types that my daughter eats most things but decides that she doesn't like them from time to time. She's served what the rest of us eat. Great, Beverly, you're starting off really good. So we can work, we have we have things to work on. I would wonder if there is a medical issue behind it, whether there's reflux or not in her history. And we're going to get to reflux here in a minute. Food's processed in the mouth. It's then swallowed, and of course then it's transported to the esophagus for further processing and then to your GI system. So already we have lots of things that could possibly hinder kids from having, active, positive meals. So if we're not good with our mouth, and if we have a kid that's really just sucking or doing a phasic bite where they pop it in their mouth and then they just kind of suck it back and don't really move it from side to side, then they're not able to lateralize food and not able to break it down further for digestion. So they may swallow bigger lumps, or they may take a really long time to eat, or they may even pack it in their cheeks and use a lot of fluids to break it down. And so we want to take a look at their oral motor structure, and that's where we can work closely with a speech pathologist or a physical therapist to work on some oral motor exercises. And of course, I can always give the coordinators who you guys are related to some of those oral motor exercises to show you how to do to help strengthen the lateralization of food so that they can work on crunchier foods better. Even thinking about dental problems, because dentists are very big, hairy, scary things for our kids, that might even be a reason that we're not eating, because it all starts in the mouth. As it goes down and we talk about it's transported, well, our muscles automatically do a peristaltic wave, which brings the food down our stomach, right? And if that wave isn't working correctly, sometimes the food will go up, sometimes the food will go down, and sometimes it sits there and goes up and down and up and down. Well, that's reflux, and we're going to talk a little bit about gastric reflux because that's really common. Many of my kids who have feeding problems now at the ages of 3, 6, 8, 10, they've had reflux in the past. So, and it doesn't surprise me that we're still having problems, because without management, reflux can come back. So the other thing that in the esophagus is if we have reflux, we get these burning holes. And I don't know if any of you have ever suffered from like acid in your stomach, or you ate something that didn't sit well. Acid in the stomach is painful. And so us as adults, we wouldn't eat either because it's painful. I don't want to eat right now. But if a child has some severe acidic acid sitting in their stomach, they're not going to want to eat either. And again, no matter what protocol we put together for feeding, if he has or she has some medical reason that they're not eating, then we're just making it worse. So that's why we always talk about having it also managed by a doctor. I see people are typing, so I will let you go ahead and do that. So the development of feeding skills over the first few years of life depend on proper functioning of those structures, and it occurs as a result of the central nervous system development and learning. So this is all related to healthy development, right? We got to get our nutrition in to help our brain work, to have our healthier development and learning. So that's why families, I don't blame you when you're struggling and your child's only eating 2 or 3 things, to use more what we would probably call dysfunctional feeding habits to get your children to eat more. Hey, you have to get them to eat, and we know how important that is. Carrie says that they had a therapist that came to her house to teach him to eat, but it seems like things did not really improve. And Carrie, your therapist, your coordinator is on tonight, so he and I share a similar area, and I have no problem collaborating with Omar to see what else we can do. So sometimes it depends on the feeding protocol and the consistency of it. I'm going to teach you one tonight, and we'll see what happens, okay? So, of course, this is a no-brainer. Children without feeding problems, for the most part, eat because it's a pleasurable experience. It fulfills nutritional and caloric needs, and certain foods taste good. Think about the social experience. I mean, when we get together with people, what do? We typically eat, or we socialize over food or drinks, and it's a very pleasant experience. Not so much for our guys, and not so much for my families, because eating is just such a struggle. Kids with feeding problems, Eating is not as pleasant as an experience. We may have the medical issues that I've talked about, failure to thrive, gastroesophageal reflux, thrust of the tongue, which is a bacteria that grows on the tongue, tube feeding, or sensory issues that hinder typical feeding development. And then we look at those environmental factors that we're continuing to do to maintain those mealtime behaviors. And again, I know that's why you guys are here tonight, because you know what you're doing, you need to change. Something needs to change. So why won't he eat? Well, the first thing I always tell all of the coordinators, and I always ask my parents, is there a medical or physical basis for the child not wanting to eat? The very first thing I will always say, have they been cleared? Have they gone to their doctor to see if there's a medical reason they won't eat? If we've already gone down that path, then we can take a look at the environment and the behavioral issues. We want to make sure that orally everything is working appropriately and they're eating, that they're capable of breaking down those textures that we're giving them. So we always ask, is there a medical basis for why they're not eating? Some of the medical issues that we bring up to the parents or the doctors may talk about, again, is gastroesophageal reflux, which is that acid that's in the stomach, and it kind of repeatedly enters and goes down and up in the esophagus. And swallowing becomes difficult and painful, and kids do what adults would do. They stop eating because that's a painful experience. Then, of course, on the other end, literally, we have constipation or lack of fiber because of the things they're eating. With the lack of fiber, we could also have that motility issue that I talked about, the peristaltic wave that isn't pushing the food down. And then pain with defecating and avoiding eating altogether. I know that there's times that we've probably all experienced constipation in our lives. We're adults, of course we have, and you don't want to eat it. It's painful. And kids that are having constipation problems, this is a medical issue that needs to be looked at by a doctor. And then on the opposite side, diarrhea. If we're having a lot of excessive diarrhea and a kid drinks and drinks and drinks all the time, there's a possibility that we're looking at an allergy to the preferred foods that we have. So that's another thing that you have to talk to about your doctor. Of course, food allergies, you have signs of nausea, vomiting, the diarrhea, as said above, rashes. Milk allergies are, of course, the most common, and you would adhere to the allergy-safe diets, of course, if that's the case. And again, these are all reasons that we would say, please go check with your doctor first. So some of the other things, remember now the mouth, if we have oral motor delays, we're going to have problems with the tongue and the movement. Lip closure, especially with our kids who are very weak in their muscle tone, may result in texture issues and chewing difficulty and basically fatigue. They may start out eating really well and then they fatigue shortly after they get going, and they won't eat the rest of their meal. They'll start off good, but then they just tire out. It could be an oral motor difficulty that we just don't know. Dysphagia doesn't sound like any of the people on this training need to worry about the dysphagia, but dysphagia, again, is for those kids that have difficulty eating and breathing at the same time, which may lead to aspiration. So they can aspire the food into their lungs, which could cause coughing and gagging, wheezing, choking. You might hear they may constantly sound wet. They may constantly sound like they have a cold or something, and that's because they may have some dysphagia issues where swallowing is difficult and swallowing and eating is difficult. I had kids all the time in the hospital. When they eat, they would pop the food right up into their nose, and talk about an aversive thing. And of course they wouldn't eat it. It's just too painful and too aversive. And then delayed gastric emptying has a lot to do with the way your stomach breaks down foods. So the doctors may give you some kind of medication to help you further break down foods because your stomach isn't working properly to do that. We had a little guy in the hospital that his meal would last 3 days in his stomach. He didn't have anything to help it break it down. So his metabolism, we had to work on everything, giving him all sorts of medications to help him finally start breaking down foods. Pretty significant weight loss, as you can imagine, because he would eat only every 3 days possibly, and of course then he would have severe diarrhea. So just looking at that delayed gastric emptying also could be a possibility. So I used to have a video, and I haven't posted it on the new training, and I want to. But the common medical possibilities that they may check for, they may check for cardiac problems. If you have some cardiac issues, you'll slow down, you tire, fatigue easily while you're eating. We talked about some respiratory diseases or issues, so that can also slow down, not make you feel well. If you're constantly wet, and just think about it yourself, if you're not feeling good, some people eat when they don't feel good and some people don't at all. And then the metabolic diseases, like I was talking about for this little boy who just couldn't break down his food in his stomach. So those are some other medical possibilities for a reason a child doesn't eat. And basically, again, we always talk about consulting your GI doctor and just getting them medically cleared that this is not why they're not eating. Typically, some of the tests that they do, they'll do either an endoscopy or a modified barium swallow. To the right, this film that you see here is a modified barium swallow. Basically, the kids drink a pretty thick white liquid. It is flavored, but many of our kids don't like it. But it shows us what's happening. It shows us what's happening in the mouth, how the liquid is controlled in the mouth. It shows us what's happening as it goes down through the throat, into the esophagus, and into the stomach, and what happens with it. The kids are brought back several different hours to see where the barium is in their body, to see what the gastric system is doing. Is there a delay? Is there not? Is it moving through the food fine? Are they refluxing? And this will show it very clearly if they're popping it up and down their esophagus or up in their nose or in their lungs. It shows it very clearly. So those are two ways that the GI doctor may test for any issues with feeding. So again, feeding disorders can be medical and physical in basis, and thus result in environmental variables heightening feeding problems. And so we're gonna start moving into the environmental variables. Does anyone have questions about the medical issues right now? Okay. So I'm going to go on to talk about some of these environmental issues that maintain some of our undesirable meal times. So none of you, I'm sure, right, are experiencing any of these things: refusing to get into the high chair or their chair. At 10 years old, they're not in a high chair. Crying, turning the heads away, batting at the spoon, clenching the teeth, spitting out the food, gagging. They become great at vomiting, so we don't get the food anymore. Throwing foods, not sitting at the table, as you know, you guys have told me 2 of them just don't want to sit. Their attention span to eating. How long do you guys think a meal should last? Just throw me out a number. How long do you think a meal should last? Okay, so Carrie says 30 to 40 minutes. Sometimes longer. Carrie, I think you're talking about your own meals. 20 minutes, Jenny thinks. Okay, so basically a meal should last no longer than 15 minutes. They literally, if that long, they get 15 minutes at lunch. That's it. Most of the kids are finished prior to 15 minutes. So I know the kids can do 15 minutes, and we typically don't ask a kid who has severe behavior problems at a mealtime to sit longer than 15 minutes. So that terrifies some of you. How am I going to get the food in him? There's no way he'll eat in 15 minutes, but we're going to talk about a different kind of protocol to encourage them to stay and do what they're asked to do. I see Beverly's typing. So typical responses for those behaviors that we just talked: throwing food and not sitting down. So these are the typical environmental responses that we do. I don't see Beverly's thing didn't come through. No meal is conducted. We terminate the meal. We ignore the behaviors, and these behaviors may be signs of medical issues. We give only preferred foods and liquids. So instead of fighting it, we just give them, and I'm going to use Carrie, I think it was, or Jenny, so we're just going to give them the quiche, right? Jenny was. And that will be easier than working on something new. So the yelling, we may yell at them for all good intentions, coaxing, come on, do it, here's the plane, right? Force feeding, I've seen a lot of headlocks in my days just to get them to eat, and I get it. It's scary. You want your kids to have the nutritional substance that they need and get those calories in. And then modeling, of course. Look at mommy eat. Chew, chew, chew. Look at Sammy. Sammy's doing a really good job eating his dinner. And how's that working for everyone, right? None of these really, that's why you're here. None of them are working. We're frustrated and we want mealtime to be better. So basically, how are these behaviors learned? It provides attention or coaxing when they're not eating. So they get all this attention for not eating. Come on, you can do it, all this attention for not eating. It doesn't expose the child to a variety of food or textures or self-feeding. We've already said, oh, they're not going to eat vegetables, so I'm not going to try it. So we have actually hindered their variety. We pair eating with aversive feeding techniques. So feeding is just aversive. The whole setup, the whole environment is really aversive for parents and for child. And then removed or delayed presentation of the food or non-preferred foods. That's found to be the most common reason for undesirable behaviors. But in the long run, we end up playing chef and put our hat on and we say, oh, do you want this? Do you want this? What about this? Do you want that? Just to get anything in there. And we've really started to create a wicked aversive or routine that the kids get in because they like the sameness of the food, or they like the sameness of the activity, or the attention that they get when they don't eat. So there's so many things that can go on with our environment. Parents typically don't know what to do, so that's why they respond this way. When kids engage in undesirable behavior, I mean, you guys aren't trained, so if a kid ends up vomiting their food, meals stop, right? Well, in the feeding clinic, we clean up and we start feeding again because kids can learn very easily to get out of a meal by choking or gagging or vomiting, and we have to teach the parents how to look past some of those behaviors once we know they're medically cleared. The parent and the child engage in predictable patterns of behaviors that lead to sustained feeding difficulties. I mean, we're all guilty of those, because we just want them to eat something, and this is what we're going to provide them because it's so much easier. So here's just a couple examples. So a nonverbal child is presented with a new food. The child engages in self-injurious behavior, possibly hitting themselves in the head or picking at their skin. I had a young lady that picked every single eyebrow. She had no eyebrows left. And the behavior is taken as an indication to dislike. The caregiver takes away the food and gives access to a preferred food the child has eaten. So what's going to happen is if this chain goes on and on and on, they're going to do it again because they know eventually all they have to do is engage in self-injurious behavior, and I'm going to get my preferred food. So we're reinforcing this self-injurious behavior, and we need to change that. So there's 3 typical consequences or contingencies that can produce problematic feeding. So we have positive reinforcement of inappropriate behaviors. So they're screaming, they're crying, they're carrying on, they've knocked the food off the table or whatever. They do this for about 5 minutes. Eventually we give in and give them their chicken nuggets. So that's positive reinforcement of inappropriate behaviors. Negative reinforcement of inappropriate behaviors. We see that they're engaging in eating or engaging in not eating. We do a negative reinforcement. So we take something away. We take the food away that they're not engaged in, and we give them something else. And so we've negatively reinforced it. We took it away. So let me give you another example of negative reinforcement. So when it's cold outside and the window's open, what do? We shut the window. And now we're warm. And we're negatively reinforced because we took away the cold. So negative is the same thing as positive reinforcement. It just means that you take something away to make yourself happy or comfortable. And then a punishment, of course, so the child is eating, but they're experiencing reflux, they're burping, they're gagging, and we're ignoring all of those behaviors, and we keep trying to feed them, and it's really punishing the experience, the whole experience. So this is, again, we just kind of go over and give an example of each positive reinforcement. So the child, the parent says, don't do that when the child spits out the food. So we're giving attention. The child gets attention. The child takes a bite of a non-preferred food and spits it out again, and then gets more attention. Although our reprimands are intended here to, of course, to stop the inappropriate behavior, unfortunately, we are reinforcing that behavior, and they're going to keep doing that, and it's just creating this horrible cycle. And again, it's not intended to be that way. It's just how it happens. So again, negative reinforcement, the removal of an unpleasant or aversive event contingent upon behavior. So if we give a real high texture, one of the highest textured foods is hamburger. I don't care what you do with hamburger, you cannot puree it down to be smooth. So when we have kids that have big texture issues, we may do what's called texture fading. And if we try to puree it to baby food consistency, hamburger does not do that. So let's talk about, like, we give them one of the highest texture food, hamburger. Refuses to accept the food and knocks it off the table and cries. The caregiver removes the food. The behavior is negatively reinforced because we took that food away. But this may be a kid that can't handle that texture and doesn't know what to do with it. So in order to escape it, that's what they're doing. And so the kid is negatively reinforced because we've taken it away. What we really need to do is look at the texture in this situation and reduce the texture if possible. So in an example of punishment, that behavior that is punished is followed by an aversive event. So this is like when the child is eating appropriately, then they experience like discomfort. Maybe it's reflux like we've talked about, or choking or painful swallowing. And we keep presenting that same meal. The child refuses because it's so punishing to go through that. And typically that's a kid that we're really looking at medically so that we can clear them medically and make them feel safe about eating. So there's different types of feeding problems. We've talked about, or I think I've mentioned or just hinted at, insufficient food intake. This is where you've got your low weight. We're worried about weight here. The refusal of foods completely, selectivity for types and textures, and inadequate calorie intake, so they're below their weight on the weight curve. There's another feeding problems which have to do with skill deficits, where we're talking about kids who have problems chewing and sucking and swallowing, and or maybe even self-feeding and task analyzing that. And then we have disruptive behaviors, so crying, spitting out of food, pushing away food, and being out of the seat. A couple of you talked about being out of seat, and aggressive, and self-injuries. So there's really 3 different types of feeding problems that can be attacked in different ways. All of them, of course, you start off with medical intervention, which means having them seen by a doctor to be cleared. So many of our kids, just like homework or being out of school or asking them to do something they don't like, we have to motivate our kids to eat new foods. Well, how can we do that? Grandmother's rule, right? Eat your peas and then you can have your cake, is many times a protocol or a rule of thumb that we're going to talk about here. So the protocol reads, a young girl who ate only 7 foods, including chocolate peanut butter candy, was rewarded with it for eating a new food. So the girl was presented with a small bite of new food along with some of her preferred foods and was given a large piece of candy immediately after taking a bite of the new food. So she liked the chocolate candy. She took a bite of peas, a small bite, 1 pea on a plate by itself on a spoon prepped. She took that bite, boom, she'd get a large piece of candy for doing this. She would be rewarded for trying a new food. Because the candy was highly preferred, she would take a small bite of a new food in exchange for a large piece of candy. So as her acceptance of her new food improved, the size of the candy bar, right, or the size of the new food increases systematically, and the candy bar bite decreases. Eventually, the girl was required to take several bites of the new food before receiving a small bite of candy. The treatment was discontinued when she would eat a specific portion of her meal to receive candy. Eventually, she would eat a meal without receiving any candy. Again, this is just an example of a child, and her reinforcer was the candy. Some kids that have feeding problems don't necessarily have a preferred food like that. And you have to use things that are more tangible, like access to a puzzle or toys or maybe a movie or a TV show that you can turn off and on with the remote. I can't tell you, Barney was the #1 thing when I was doing feeding, and I know every Barney song, and I went to sleep every night singing those songs. Many times, many of our kids would, bite for bite, be able to watch a 30-seconds of Barney. We would turn it off, ask them to take another bite, turn it back on, turn it off, and we did that for 10-bite sessions or depending on how much food that we asked them to take in. That's how we got them to eat new foods. Any questions about this? It's hard when you guys aren't with me because I'm sure you have hundreds of questions. Okay. So this is not eating. This is licking. So any of the foods that when you do your daily log, if you're going to do one for us, make sure it's not, we had a kid come in and the parents gave us this list of foods that he would eat, but he wasn't eating anything. We brought all that stuff in to do a sample meal, and he licked the salt off of the pretzel, or he, and I wonder why, Beverly, your stuff isn't showing up. I don't know why it's not showing up. Lick the food or lick the inside of this or that, but that's not eating. So we need to make sure that they're ingesting it. I love this little picture because if you could notice real closely, that's a turkey, so it's so like apropos for this time of year. They took the top of the cookie off and made a little turkey out of it, so if any of you want an idea. Your daughter likes to lick, and that is interesting because if you were to take her to a nutritionist or a doctor, and I don't know if you have, Beverly, they would talk about what is she missing in her diet that makes her want to lick, and kind of evaluate that. So that's really interesting that they like to lick. Some kids are just really sensory. That's how they get their sensory input too. So taking a look at it from two different ways. It could be something missing in her diet, or it could be a sensory issue. I'm going to pause a little bit as people are typing so I can answer some questions. Carrie, you said your son licks things he doesn't like to eat. Should I allow that? I say absolutely, because he's at least tasting. Remember, 10 to 20 times tasting something before you like it. Absolutely. I would put I did it with an older kid. We and the whole family actually needed to increase their variety. So I had them put a tray of raw vegetables, of all different vegetables, every meal in their house. And everyone had to take a bite of a new food that they don't care for. And now they love vegetables. They order them for dinner when they're out to make sure that they have some vegetables on the plate. Absolutely. Have him go ahead and lick things. At least he's doing that part. At least he's a little bit adventurous. Beverly says she mouths things too. It was addressed on her IEP this year. And that's a developmental stage for her, so she may be developmentally delayed in those kinds of interacting with her environment. But that's interesting to note as well, that she's doing that not just with foods but non-food items. Penelope will sometimes take food but store it in her cheeks and never eat it until we have her spit it out. And Jenny, that's a really, for me, that signifies something oral motor, and I'd love to see her, I'd love to see a video of her eating, so that we can take a look at it, take a look at her swallow, take a look at her eating a food, and see what happens. Because I've got people that are speech pathologists in Orange County that work specifically on feeding that I could pass those names on to you. And that's more for oral motor issues. So as Jenny's typing, okay, so it's mostly new foods. And Jenny, again, I'd love to take a look at that. So I talked about, that one example showed a young lady eating cookies per bite of a non-preferred. Well, tangibles, right, to have a tangible non-food reward, Identify items, activities that reinforce your child, and we have what's called a reinforcer bagger box. That reinforcer bagger box is only for feeding, only. So the only time that they would be able to interact with those toys or those favorite things that they want are during eating. So if they take a bite of a preferred thing, then they would get access to a tangible. Some of our kids change a lot, so that's why we talk about a bag, so there's different things in there. Some of our kids just like one thing. But that bag is made and used only for feeding, and it's brought out. So now feeding looks a little different. There's a little bit of motivation behind it. It may be a little exciting. Oh, I get to play with this. I get to play with my car. Whatever that is. And it's a really big fun time with mom or dad or maybe my brother, that when I'm doing the right thing, everyone's engaged with me. When I don't eat, no one pays attention to me, and we'll talk about that protocol a little bit later. I don't know if anyone has ever seen a cat play with these busy boxes. They're so much fun. My mom has a cat that does it all day. So this is a tangible protocol, which means what we were talking about, whether it's food, or primary reinforcer, or a tangible, something they can play or watch. This talks about using a video, but you can also use your toy. So basically, you allow the child to watch the preferred video or play with the preferred toys a few moments while you're preparing the food. So you bring them to the table, you have them sit down, you either have access to your iPad that has the video on it or whatever. iPads are so much more convenient than having to move the whole table in front of the TV nowadays. And they're allowed to play with those preferred toys while they're getting their food prepared. Then you pause the video or remove the toys and tell the child it's time to eat. And we're going to start the timer. And here you see that 15 minutes is standard. The reason we say standard, some kids have they need more processing time. And again, we need to be conscious of that. So if you have a kid that needs a little bit more processing time, we might go a little bit longer. But meals that are an hour, hour and a half, 30, 40, 45 minutes, just too long and obviously just maybe too punishing. So you pause the game and you tell them it's time to eat. We're going to present the food and tell the child that as soon as the child takes a bite, he can watch the video or play with mom or get to play with his toys. And then, so as soon as the child takes a bite, when I say take a bite, guys, when I talk about this protocol, the bite of the new food is presented, and when I'm in front of you doing this, I literally have a spoon. I show you a spoon with a pea on it and a plate. That's it. There's nothing else on the plate. It's not this whole mound of peas or avocados or whatever you want them to eat. Think about the cost of that. Think about it for you. If you don't like that food and you've never had that food before, you've got this mound of food in front of you that, and I'm saying mound, think about their perspective as a kid. One bite looks so much easier. Oh, I can do that. I can work myself through this to do this. Just that one little bite. So again, so when you present the food, it's on a spoon or a fork that is prepared with the bite that you want. The bite size is no bigger than a pea. Tiny, tiny, tiny bite to start with. That's it. Once the child takes the bite, the child is praised. Great job taking a bite of your new food. Oh, that's so awesome. The video or the toy or the whatever you're going to use, they get access for 10 seconds. They're playing. You're involved with them. You're talking. The video is then pressed on pause, and the child is asked to take another bite if we're on a 2-bite or more protocol. I usually start this protocol with all preferred foods so that they learn the system first. They learn the protocol first. Take a bite, you get to play. Take a bite, you get to play. So a week of doing this protocol with preferred foods, you stop presenting non-preferred when we start this protocol. So you do a week of just all the preferred foods. And then the next week we put that new food on the spoon. Okay? And now they have to take a bite of that new food before they can have the rest of their meal. But they already know the protocol. They already know what they have to do. They've had a whole week of engaging in taking a bite and getting to play, taking a bite and getting to play. So now they just have to get through, okay, this is a new food. I'm going to cry a little because I used to do that. I may even push it off the table. That's why you're going to have more reserves constantly beside you. Don't have to go to the kitchen. You don't want to have to get up. If you're covered in mashed potatoes, you'll know how I felt. But you don't want to have to get up. So If the child is on this tangible protocol, and if we're doing more than one bite, then yeah, go ahead and turn the TV or take the toy for 10 seconds. Say, it's my turn. Okay, as soon as you take a bite, we get to play. If you don't take a bite, we don't get to play. We ignore all inappropriate mealtime behaviors. This is where you have a stone face. You don't do anything, even if they're gagging or they're pretending to choke. You're going to have a watchful eye on them to be careful, but we're not going to overreact. We're not going to stop the meal, and we're just going to ignore all those behaviors. If they haven't taken a bite within 10 seconds of you presenting the food, you take the plate and everything away, and you turn your whole body away so they can't see your face or anything, and you don't interact with them for 30 seconds, and then you turn back. And you say, if you take a bite, we get to play. If you don't take a bite, we don't get to play. They really, if you do a whole week of this protocol with preferred foods, they get into it, they love it, mealtime is really happy. Next week we add that one new bite of that one new food. And it takes a while, guys. It's not going to happen overnight, but all of a sudden you see them starting to experience new foods, getting that 10 to 20 trials of a new food before we see if they really dislike it or not. And then we can start adding more and more foods into there. So ignoring all those inappropriate mealtime behaviors is really important. That's what's sucking us in right now to maintain these mealtime behaviors. When the timer rings, because remember you set it for 15 minutes, the meal is done. Okay? That's why I like to do the running week of preferred foods first, and then adding the one in. If we focus on only the dinner time meal, because you guys don't have time to do breakfast or lunch, they're at school, except for, I guess, well, no, the 3-year-old's probably at school too. They're at school, and you can't work at lunch, and you can't work on breakfast because you're getting out the door. So you work on dinner. And if it's just been a no good, very bad, horrible meal, we're going to do our nighttime routine and put them to bed. We don't want to do big reinforcing, allowing them to watch TV or anything like that, because they can learn to just cry and cry and cry for 15 minutes and get out of the meal. So we put them to bed. We keep it very calm. We don't really excite them. We keep our very neutral face. We put them to bed. If they have no medical issues, guys, they have a hunger drive. And that's really important. And let me talk a little bit about this hunger drive. If you allow your child to graze, there's always food out, there's always milk out, there's always something that he can just pick up and take, or she can just pick up and get at any time, why would they eat at dinner time? They're not hungry. They have access to it all day. You should have 3 meals that are designated in a schedule. This is the time we're going to eat. And then 2 snacks. And your snacks are not a meal. The snacks are a snack. It's small. Don't allow to have the water out at all times, because they get full on water or milk or whatever that's out. You really need to control, especially for kids that are giving you a tough time with feeding. You need to be vigilant about not letting them graze, making sure they sit, because, by the way, they all sit at lunch at school. They're not running around. From day one, they've sat at the table, so I can guarantee they can do it at your house too. If the expectation is that you sit, you sit. As soon as they get up, everything turns off. There's nothing. And then they're directed back to the chair. So working on some of those protocols, making sure that there's a motivation for being there, because you've got those toys and it's exciting, and there's some motivation to sit there too. So again, 3 meals a day. Do not have access. Put the no access sign, so the international no sign that's red with the line through it. Ask your coordinator to have you get a visual support like that, and we put it on clear paper so you can see through it, and you put it on the pantry, or you put it on the refrigerator. Putting it on the pantry or the refrigerator says there's no access right now. There's no food right now. When that comes off, the child knows that it's time to eat. You're going to create that hunger drive, which we know they have if there's no medical issues. And now they're going to be more willing to try something for you. So stop doing the grazing and having the water out or the milk out at all times. You might get an extinction burst because they're used to having those things out. And if you've not gone to the behavior basics, extinction burst is when that behavior goes up and up and up and up and up before it goes down because we've changed something. Okay? So again, it's really important that we are specific with our meals. 3 meals, 2 snacks, no grazing, and watch the intake of liquids, because if they have them, they're not hungry. So priming the pump, we have access to the rewards so that they know it's coming. We're going to use preferred foods to establish that rule and routine, like I said. And we're going to start with preferred foods and then non-preferred foods, okay? Sometimes people use the protocol of, let's start with their new foods and end with one bite of non-preferred. What do you guys think happens with that? You've got a full tank, and now they're going to start crying and crying and crying until they're, and boom, they vomit, and they vomit everything they have in their stomach. So watch out with starting with preferred foods and then a non-preferred. That's why we put the non-preferred food in the front, because they don't have that all sitting in their stomach, okay? So we always start with that non-preferred food once we've done an established rule and routine week of using preferred foods so that they know what to look for when we start with the non-preferred. Tasting sessions are awesome. Tasting sessions are structured times or period where the goal is to have the child taste new foods using the tangible protocol, so the protocol we just talked about where they take a bite and they get to engage in something positive. It's done outside of meals, so it's something that's completely different. Once the child begins to accept the new food with little to no difficulty, you can begin to include it into a family meal. So it's done like a discrete trial training where we're taking discrete little things. We have the trays that have like the 5 different areas to put different vegetables or whatever, and the dips in the middle. You would use something like that to set up the food. You would ask the child, you just start the timer for 15 minutes, and the tasting session protocol is in the book that's noted in the notes, how to do that. So you would and it's outside of meals. Some therapists will do that for you. If you have a therapist that's working with your child, they may run that tasting session for you to increase variety, and that's why we do tasting sessions. Basically, you say, okay, take a bite. If you take a bite, we get to have fun. If you don't take a bite, we don't get to have fun. So they take a bite. There's different levels. They can smell it, touch it to their lips, touch it to their tongue, put it in their mouth and spit it out, put it in their mouth and swallow it. There's different levels to the protocol. And as the child goes through and we start shaping up acceptance of new foods, some kids just have to have it on the plate in front of them. We have to shape up just allowing different foods on a plate in front of them. So the tasting session is really a fun way to do it. Over the summer, I hope to do a feeding summer camp, sort of, where we'll be doing tasting sessions. So the kids would come and we would run different tasting sessions. And anyone who has come to any of my feeding sessions, I will pull your names and say, hey, would you like to try this tasting session camp over the summer? So if you're wanting to do that, please look for that over the summer. We're going to try to put it together. Of course, we have to look for funding because of the foods that we're going to need and things like that. But I think it would be a really neat way to teach parents how to do it and to increase variety of kids, for a variety of kids. Remember, you have to be patient and consistent with all of these protocols, because if you're not consistent and you give in, you're just going backwards. You've only taught the child to refuse longer. So you just need to be patient. It takes time, so you just want to be patient. So you want to let the child that it's time to eat. If you take a bite, we can play or watch the video. If you don't take a bite, we cannot play or cannot watch the video. That's that consistent part. And if you can, for parents, what we used to do in the hospital is make up that rule. And we put it very big for them to put up in their house, and so it would be facing them for while they're feeding their child, and it just kind of calmed them. It gave them a sense of, this is what I need to do, and this is the routine. This is what I have to do. Remember, our kids like that routine too when it's nice and calm. So again, this tasting session protocol, it's written out here. It's in the book as well. It's a 30-minute to 1 hour, depending on what you have the time for. We start with tiny tastes of foods, and the initial goal, remember here, is not to get calories. It's just to try new foods. So we're not worried about the amount. If the child refuses to take a bite, we touch the food to the child's lip and then praise the child and give them the reward. This is really just a positive, fun protocol. We want to teach them that it's okay to try new foods, and when the timer goes off, we terminate the session. It's all done. And we had a good time. We had a great play session, and Mommy tried new foods, and Sissy tried new foods. There's a game board that a colleague at UF has created with this, and I think that's what we're going to use for the summer session. This slide just talks about the different oral motor development that kids typically have. And some of our kids get stuck in this phasic bite phase where they're just sucking it and flipping it back, or sucking and not chewing their food correctly. And that's when we have some oral motor issues. And I show you this before we talk about the problems with textures and chewing. So we do have texture fading protocols. You can puree anything, believe me, and we did to all the wonderful tasting hospital food that we had access to. But you can make all of these different textures with any food. So if we have a kid that's having problems with textures, we may lower that texture, or if they're sensitive to different, they have some sensory issues with foods, we may try texture fading to increase that. And as we're texture fading, we're going to use any food, so we're increasing variety at the same time. Oral motor skills are not uncommon for children with disabilities to have a deficit in their oral motor skills because of different structures in their bodies, or they don't have the tone. So sensory motor treatments like tongue lateralization and lip closure and chewing practice and texture fading is what we can use to help these kids that have more of an oral motor deficit. So, independent feeding. Lack of independent feeding is also difficult, especially when your kid is older, right? They're not eating enough and they don't accept a variety of food, and it turns out to be like food refusal. So what can we do with those kids that are older? They should be feeding themselves, and what can we do? So basically, occasional self-feeder become a, okay, let me start over. Occasional self-feeders, we have to establish a time limit. So we have no snacks, so we create that hunger drive. We require to independently feed. We may then do a task analysis. What part of this aren't they able to do on their own? What part of this is it distraction? What is it that they can't get enough food in? They can't sit at the table, I think some of you have said. So we may use positive reinforcement strategies to keep them at the table. And at the last resort, we turn to a non-self-feeder protocol where we're feeding them. Now, of course, we don't want to create dependency on that. I have a lot of kids that sit there like birds that just want to be fed, which is ridiculous because then they won't eat at school. So if you're feeding him a lot at home, that's why he's not feeding himself at school. And I can tell you many teachers won't do it because they don't have the staff to sit there and feed the child. So we've got to really task analyze why they're not feeding themselves. Okay. So there's different behavior modification programs that are used to help individuals feed or increase their feeding. So positive reinforcement, rewards for positive feeding behaviors, and we're going to probably stick more to this. A differential reinforcement is for food selectivity and escape of a targeted food, and you're going to see us kind of stay in these two areas. Escape extinction is the story I told you in the very beginning about the young lady that covered me with mashed potatoes. It's for food selectivity or just escape aversion to stimulus, which is what we're trying to do is have them eat. Those can be very long meals. Again, it was 3 hours for the one girl to take one bite. And those are typically done in a clinic where you have support and you're not doing them by yourself. Most of those kids are pretty low weight, and they're typically on a G-tube or an NG tube, which G-tube is the stomach and NG tube is through the nose. So let's look at this positive reinforcement protocol, and this is kind of what I want you guys to be thinking of in the way that you might approach a new way of doing meals. So prior to treatment, guys, you're going to keep a daily log like I've asked you to do. You're going to stop presenting non-preferred foods, and you're going to determine what your reinforcers will be. We are definitely here to help you do that. Select your targeted foods and determine amount to be consumed. Let me give you a note here on selecting your targeted foods. You don't want to go, if your child's only eating, I think I saw rice and pasta, we're not going to hamburgers. We're going to a food that's very similar to what they're already eating, and then we expand from there, because remember, our kids are very into that sameness, so we may do something that's the same color, close to the same flavor, and expand outward that way. We're not going to pick something totally different that the child has never seen. So we're going to watch our selection of food. I mean, we had kids that we just changed the yogurt from strawberry to blueberry. We kept it yogurt and then increased to different foods as we went along. And then, of course, determining amount to be consumed. If we're doing one-bite protocol or if we're really looking to get calories in the kid, that's going to be different than a one-bite protocol. So what the environment should like. The child should be seated at the table. Yes, I said at the table. They can do it. They do it at school. They sit at the chairs or the tables at school. If they're in a high chair, of course, for safety, you want to make sure that they're strapped in because they are higher and they can tilt over, so you want to make sure that they're safe. If needed, a booster seat because the chair is too big. I'm very big about making sure that their airway is all open and we're all good for feeding. I talked about this before, that wheelchair-bound children must be repositioned in their chair for that airway to be proper for feeding. We want to turn off all distractions, which means your cell phone as well. Everything goes off when we're trying to do feeding. Even, just text or tell anyone that's possibly going to call, we're going to sit down to eat. We're not turning on our phones. Doors, TVs, music, whatever. Everything's off. All distractions are off. And remember to have that reinforcer box that I talked about beside you for easy access. You don't want to be getting up and running and getting a video or anything. You want everything ready before you eat, before you even start the protocol. I talk about a floor mat because it can get messy as they go through their refusal phase of, hey, this is a new food, I don't want to try it. I use a shower curtain, just like a shower curtain that you could take outside, shake off, and hose off. Especially for those who are worried about food on the floor. Kids that are messy, we don't sit there and wipe them and wipe them and wipe them and wipe them. That's attention for a behavior. So if you have a kid that's has sensory issues to food, you will teach them to wipe themselves. You will put your hand over their hand and you will show them how to wipe themselves, but you're not going to make it fun and attention-seeking to wipe them all the time. Dysom is awesome. Dysom is, gosh, I don't think I have any here. But it's I call it fly paper. You can get it through PT or OT stores. It's blue or it does come in red, but it's kind of like the shelf lining you also use in your shelves that is more sticky. Once you put it on the seat, the child can't slide down their seat and get out of the chair. It's like fly paper. They can't go anywhere. So I like to use Dysom in the seat just so that our Houdini to escape from our chairs just can't get out. So the positive reinforcement protocol, there's two types: access to preferred events, contingent upon food acceptance, and then offering preferred foods or social praise after the child has accepted the non-preferred. So those are the two different ways that you can do this protocol. And this is it, guys. It's really, really simple. It looks like it's been adjusted here on the slide for some reason. But, and I'll have to look at the formatting when it came into this Adobe. But basically you start off with, okay, Roy, it's time to take a bite. And then as soon as you take a bite, we get to play. If you don't take a bite, I don't get to play. So they can either go down the street. If they take a bite within 30 seconds, we're going to give them verbal praise. We're going to say, way to go, great job, here you go. And then he gets to play with his toys or he gets to watch his video for 30 seconds while we prep the next bite, if that's what we're going to do. And then we go right back through this protocol. It's just a nice little C. If the child refuses, we take the plate away, the spoon, and our body after 30 seconds, and we turn away. They are going to be crying. They're going to be reaching for you. They may even get your hair, and you're just going to ignore it, right? We're going to ignore all those behaviors. And 30 seconds, we're going to turn around and say, if you take a bite, we get to play. If you don't take a bite, I don't get to play. We don't say anything else. We don't beg. We don't coerce. We don't do anything else. If you're good, this is it. This is the rule. Now remember, prior to doing this protocol, you've already done it with preferred foods. So they already know the protocol. You're just adding that non-preferred in. So what do you do with kids who are batting at the spoon, knocking things off? This is if you're feeding the child that you would neutrally block those attempts to throw through your presentation, or if they're spitting food out, you're going to ignore them spitting out the food. Just ignore it. Remember, those are mealtime behaviors that we're going to ignore. We're going to neutrally remove the food that they've spit out and let it drool down their face. They're very good at that. Let it drool down their face, and we remove the reinforcement for 30 seconds. If it becomes a big issue, that's when you would call and talk to one of us, and they're not taking anything in. They're spitting everything out, and they know that we're wiping it away. Then we would do what's called replacement of expelled food. And you always have extra once it gets really nasty, but eventually they learn to take it in on the first time because they're not going to get away with it. But that's only after the other thing hasn't worked. How to ensure effective intervention, guys? Avoid feeding from the original containers, like I said from the beginning, because those containers are going to change, and that's going to reduce the types and the variety. You're going to vary those dishes, cups, and plates because you know they love that sameness, and they have to have that same red plate, and if they don't have it at school, they're not eating at school. So make sure you're varying these dishes, cups, and plates. You want to structure your environment. 3 meals a day with 2 snacks and no free-for-all access to liquid. Really control that. Using a visual clock also will help you to maintain at that 15-minute protocol, that only having them sit at that table for 15 minutes. They also know that time's going or time's up, and if they hadn't eaten at that time, they know that they're just going to end up going to bed, and tomorrow's another day. Make sure you thin that reward schedule out. Make sure you pair it always with praise. We're not going to do it right away, though. This takes a while. I can see you using this protocol for 2 to 3 months before we even try to thin out that protocol, because think of all the foods that we can introduce. So always pair the tangible, the cookie, the truck, the video, with praise. Thank you so much for eating that. That was great. That was awesome eating that broccoli tree. Always pair it with praise, not good boy, good girl, because they're a good boy over here, they're a good boy over there. What does good boy mean? You want to be specific with your praise. So what are some of the common reasons interventions fail, guys? It's because we discontinue it too soon. We think they're doing great, and then all of a sudden it discontinued, and the kid's like, hey, I used to have a lot of fun when I was eating now. Well, I'm going to go back to the old ways so I can have more fun. And we're unprepared for increase in problem behaviors. There's going to be an extinction burst. That extinction burst is hard to get through. That's when myself or whomever's your coordinator is the cheerleader on the phone saying, I hear them, but keep going, you can do this. I know they're crying, you can do this. Or that other family member to support you is there to help you get through it. You've got to get through that extinction burst before you're going to see the positive results. Consistency among caregivers. The protocols are simple to follow, and everyone can do it the same way, and that's what we look for. We've got to watch out for the coaxing. We've got to watch out for the attention for the non-preferred behaviors at the mealtime, because remember, the only preferred behavior at mealtime is to eat, and is to eat the preferred and non-preferred foods. That's the only time you attend to their behaviors. Otherwise, you don't attend to it. Problems with the rewards, if they lose their power, remember to have a bag or change it up. Ask them, okay, this week, what are we going to work for while we're eating? Let's look at our bag and see if we want to put new things in there. Get them involved in it, because that actually buys them into the program. And of course, pairing the rewards is also can be a problem. You want to make sure that you're not doing more praise. Depends on the child. There's a lot of kids that really like praise and like tickles and just getting in and being with the kid. They like you as the toy. I always considered myself the toy for many of these kids. If the child resists for the intervention, and believe me, they will, stay strong and be consistent. That's all I can tell you. This is not something that, think about it, especially with your 10-year-old. He has had 10 years to develop these behaviors and for you to develop your behaviors. And now we're going to change it. Of course we're going to see behaviors. So stay strong and be consistent. So establishing and attaining goals, depending on what your goal is, if it's for selectivity, weight gain, or transitioning from different food textures, we're going to have different goals. We're going to have different outcomes. We're going to want to know what that is. If you're looking to just have them eat lunch at school, then we're going to focus and target on school lunch foods, kids' finger foods that they eat at school. versus maybe what you're eating at home. If that's just depending on what your goal is, you want to make sure that you're focusing on the right thing. If it's weight gain, I'm going to really talk to you about medical intervention. But if it's selectivity, which it sounds like here, or transitioning, maybe some of you guys may have some oral motor issues, then transitioning to different textures. But that's different goals are going to have different interventions, different ways of attending to it. Different preparation too, I should say. So in review, guys, have the child medically managed. I can't say that enough. Choose the appropriate behavioral protocol to address your goal. So depending on what the goal is, weight gain, and for you guys it looks like selectivity, make sure you have the appropriate protocol, which is the positive reinforcement protocol for you guys for increasing variety. Make sure you determine your reinforcers ahead of time, really think about them, and they cannot be accessible any other time except for meals. They can't have access to them because why would they eat and play with them at the meal if they could have them another time? So this bag or this video or this whatever it is does not you don't have access to it any other time. You want to choose your target foods carefully. Remember, it should start off similar to what they're eating already, and then we'll increase that variety as we go on, maybe even through tasting sessions outside of meals. And you want to set up and follow your protocol. Even if you write it in large letters, get a dry erase board and set it so that you can see it as you face your child, just so that you remember how to do it. It's the best way to keep you sane. It keeps families consistent between feeders, members that are going to support you, grandparents and such, and people that may not buy into it. They can see that you're really focused and consistent. They may have more support for you. So the child is best managed by a team of specialists, which could include a behavior analyst, a speech pathologist, occupational therapist, as well as a medical doctor. I can't say it enough. You have to have a team approach to support what your needs are. And CARD is definitely here to help and support. I love looking at videos and helping my colleagues learn more about feeding. Obviously, it's something that if you haven't done it, it's hard to explain or talk about. But once I get them going, they definitely can do this. I train parents. You guys are the therapeutic agent. I can't be there for every meal. You're going to have to do this. So if you have any questions, of course we have time for it. If it's specific or if you are willing to share a video, I'd love to start adding videos into my presentation of parents who are brave enough to show a before and after. And Carrie's going ahead and typing. I'm going to actually stop the recording right now, but that doesn't mean we can't